Hi everyone, welcome to case session 10. And theme of this session is complex PCI. I'm Yuji Hamazaki from Japan. I'm a moderator, and in this session, and my co-moderator is Mohamed Shabi, and we have 3 panelists, and Dr. Kwon, and Dr. Hsin, and Dr. Tan. And in this session, we have 6 papers, and every paper is very interesting. So let's start from first case. And Dr. Zhang, please start your presentation.
Hi, very good afternoon, moderators, panelists, and members of audience. I'm Saad from Malaysia, so I will be talking about a case of PCI to a calcified CTO-RCA in a symptomatic elderly patient. I have no disclosure, and my patient is a 79-year-old lady. She has underlying type 2 diabetes, hypertension, mild coronary artery disease, and chronic kidney disease, stage 3. She presented with central chest pain and diaphoresis for 2 days. Examinations were generally unremarkable. Her blood pressure was stable. ECG showing T inversion in 2-3 AVF. And echocardiogram shows ejection fraction of 57% with regional wall motion abnormalities in the inferior wall. She has a very good HbA1c and LDL-C control. Angiogram shows she has a mild disease at the osteocircumflex artery and severe disease of the intermediate artery, and also severe disease at the mid-LAD with retrograde supply to distal RCA from the distal circumflex and the distal LAD. However, her RCA shows severe calcified lesion with a severe disease at the proximal RCA, followed by the CTO from the mid segment, and with the bridging collaterals from the RV branch supplying the distal RCA. Her syntax score was 19, and syntax 2 score favors for CABG. We have discussed this patient about this patient for revascularization options. However, this patient doesn't want CABG, and she insisted for PCI. So what is the next plan? Should we offer this lady for optimal medical therapy, or should we proceed with the PCI to LAD and intermediate followed by the PCI to CTO-RCA, or we should do the PCI to CTO-RCA first? So in this case, we chose the third option, that is PCI to CTO-RCA. So there are a few things that we need to keep in mind, whether we should go in with the IABP support, whether we should use the IAVICE-guided PCI to CTO-RCA. There we have also need to bear in mind that there is a risk of contrast-induced nephropathy, and this patient might require dialysis. Her JCTO score was 2, and progress CTO score was 5. So what are the strategies? As the basic principles of the crossing CTOs, we either can go for antegrade via escalation, antegrade dissection reentry, or retrograde via escalation or retrograde dissection reentry. So whenever we decide whether we go for antegrade or retrograde approach, we have to see a few points, whether there is a ambiguous proximal cap, what about the distal target, is it poor? And also we have to see whether is there any appropriate interventional collaterals are present. So based on that, we decide, and we have to switch the strategy whenever needed. So we proceeded with the PCI to CTO-RCA with SAL1 6 French guiding catheter, and we attempted with Filter XT, Gaia 2nd, Conquest Pro. We even tried the parallel wiring. However, we are not able to cross the CTO RCA. At this point, we have used about 160 mils of contrast, and we decided to stop this and to proceed with the PCI to intermediate and LAD instead. So we did a PCI to intermediate with DEB 2020 at 6 atmospheric pressure, and we did a PCI to LAD with the DES 27532. So this patient developed acute kidney injury post-procedure, and however, that improved with hydration. We plan for PCI to CTO later. So, however, this patient again presented 3 weeks later with the chest pain, ECG showing similar changes and creatinine was 121, and echocardiogram shows still preserved LV function. So we reattempted PCI to CTO RCA at this point with SAL1 6 French guiding to the right, and also the OptiTop 5 French to the left system. We attempted to cross CTO RCA with Filter XT, Pilot 150, Conquest Pro, and 9 and 12. However, we were not able to get the distal lumen. So at this point, we changed the strategy to go for ADR. So we changed the guiding to SAL 7 French guide with side holes, and we also used the RV branch with the balloon anchored for better support. And we did an ADR with loop filter XTA. However, we were not able to pass the stingray balloon down to the distal RCA, and we did some pre-dilatation with semi-compliant balloon 1.510. Finally, we were able to pass down the stingray balloon down to the distal RCA, and we crossed with Conquest Pro 12 to the distal RCA, true lumen. So we changed the softer wire to the PL, and we put another wire to the RPDA. And we pre-dilated the lesion with a semi-compliant balloon 22520 and 2515 at 15 millimeter. And we stented distal RCA with DS 2548, mid RCA with 3032, and proximal RCA with 3538. We did post-dilatation with NC 3515. And this is the final results of the RCA after the PCI. So when we look at the treatment algorithm, either you see most CTO-CC or AP or hybrid or Euro-CTO club, all treatment algorithms more or less are similar. So when we see we deal with the CTO, there are complications we need to anticipate. So usually when we see this sort of lesions, so complications can happen in patients with the elderly patients with a high JCTO score, post-CABG, and also patients with the calcified lesions and tortuosity and use of retrograde approach. IVUS is again very useful in sizing for long calcific CTOs and also to identify the negative remodeling. So ADR we use in cases where landing zone with a minimal disease, and of course antegrade wire is very close to the distal vessel lumen, and also there was a minimal expansion of the subintimal space. Collateral injections plays an important role for CTO PCI. As a conclusion, it's a case of successful PCI to a calcified CTO RCA in a symptomatic elderly patient with multiple comorbidities. Euro-CTO trial shows benefit of PCI over optimal medical therapy for symptomatic patient with CTO. We use various strategies in this patient, including antegrade wire escalation, base technique, parallel wiring, ADR with stingray. Contemporary CTO PCI comprise of antegrade, retrograde, ADR, and IVUS guided wiring. With that, thank you very much.
Thank you. Nice presentation. And this case was very difficult because of severe calcification.
Yes.
And but you could get success using ADR system.
Sure.
And any question and comment from panelists?
Hi, I'm Osung, Kwon from South Korea.
Yes.
Dr. Jen, thank you for your nice presentation and wonderful case. I'm not gonna point the successful CTO PCI, but I'd like to ask your basic principle when you encounter CTO vessel as well as the other non-CTO vessel, disease vessel. When you encounter this kind of multi-vessel disease, including CTO, what is your principle to perform PCI first? You did you attempt RCA CTO first, but for me, generally I prefer to perform non-CTO PCI first and then move on the CTO. So sure. I wonder your principle.
Sure. Yeah. So actually, what we did was we initially wanted to do the PCI because the elderly patients, but of course these patients' LV function is quite preserved. So I think it's okay to proceed with the PCI to the non-CTO vessel first. But of course, when we look at the vessel, the flow to the left system is quite good, and the circumflex is well. No need any intervention. So we thought we will do the PCI to CTO RCA first. And again, when we failed, we straight away changed the strategy in the mid, and we proceeded with the PCI to the intermediate and LAD first. Then we proceeded with the CTO later. Yeah.
Dr. Khin, thank you very much for this wonderful case. Your problem in the CTO, right, in this case, is a uncrossable balloon or the heavy calcifications with uncrossable balloon. Yeah. And you tried several times,
sure,
but you didn't use any procedures for debulking of the calcifications. How could you succeed in this case? I know that you succeed, but sometimes it's so difficult. So what's your advice to the operators?
So actually, what we can do is in these cases we can use either debulking with the either rotablations or I mean the OS. But of course, we need to see, because once we did a multiple attempt, in this case there was a dissections and all. So we actually multiple times our wire went into the subintimal space and is around false lumen. So that's why we didn't use the debulking for this patient. But of course, we in this case we managed to open well, even without a debulking. Maybe we are lucky. Yeah.
Yeah, you are lucky. Yeah. You are lucky. You used different wires, balloons, and finally succeed. Thank you.
Okay, retrograde. I mean, the retrograde approach is an option for this patient as well. But of course, when we see we don't have a very good septal branch to go to the retrograde to the distal RCA, whatever the retrograde we have is from the very distal circumflex or the distal LAD. So we anticipate a lot of complications, and also again, this is a CTO with the calcified lesions. We may even have a difficulty to cross again. And that's why we didn't do the retrograde approach in this case. And also when we look at the antegrade approach, our wires were actually very close to the lumen. So that's why we think that we may be able to do ADR and we can get through it. Yeah.
Okay.
Thank you.
Any question or comment? Okay. Okay. Your time is up. Thank you very much.
Thank you very much.
And we move on to our next presenter. Next presenter is Donna Shu-Han. Okay. Please start your presentation.
Hello, everyone. I'm Donna Lin from National Taiwan University Hospital in Taiwan. And today I'll be sharing a case in which we manipulated with an SVC filter. And without further ado, let's look at our case. I have nothing to disclose. So this patient is a 58-year-old woman with a history of non-small cell lung cancer. Significantly, she had brain metastases prior to this admission. And this time she admitted with progressive exertional dyspnea and orthopnea for 1 month. She also had significant bilateral upper limb swelling and exertional facial plethora. So from these photos, you can see that her face and her upper limbs were markedly swollen. And due to these symptoms, she had a CT done, which showed tumors at her SVC with SVC encasement. So under the impression of SVC syndrome, she was admitted for further intervention. And this was her diagnostic venography. You can see that contrast injection from bilateral subclavian veins showed a severe filling defect in her SVC, which was attributed to her tumor. And so for this lesion, we decided to deploy kissing stents. 2 Venovo stents were deployed from the SVC to bilateral subclavian veins. And after stenting, we did post-dilatation with kissing balloons. But at this time, after kissing balloons, we could see that contrast injection from both SVC also showed a filling defect in her SVC. And also that the patient was suddenly severely dyspneic and agitated. And so what should we do? So a couple of things to keep in mind. Firstly, with tumor encasement, external compression from her tumor, but in reality, there was much thrombi in her lesion. And so after aggressive balloon dilatation, the thrombi extended in length and was involved in her SVC. So the problem we were facing at this time was acute stent thrombosis, also complicated as is evident by her symptoms, her history of brain metastases. So at this time, it was favorable to avoid together and rental. And another thing was before we closed the procedure, bailed out stenting was necessary, and so needed to do Luminex stents from the patient's bilateral subclavian veins to her SVC. And as you can see, after bailed out stenting, SVC flow was established. This is a diagram to show what we actually did. And before we close the procedure, you can see that the Illuminex stents extended further proximally to the RA. And unfortunately, however, the arrows you could see pointed out to much thrombi. So what should we do next at this time? So things in mind at this time was the patient had a huge thrombus burden. And so because she was refractory to parental anticoagulation alone, catheter-directed thrombolysis was favored. But due to her large thrombus burden, there was high risk. However, the next question was, where exactly should we land our SVC filter? So this is a diagram to show what we're facing at this time. You can see that the thrombus was almost completely filled up the Illuminex stents and was very close to the SVC and RA junction. So we could consider a landing zone here. Let's call it landing zone 1. So the pros of landing zone 1 would be that the vessel size here was adequate for deployment of the SVC filter. But unfortunately, the retrieval of the filter would be impossible at this place because the filter would theoretically entangle with the stents. We could also choose to deploy our SVC filter at this place. Let's call it landing zone 2. And the pros would be that there were no risks of stent entanglement, and so retrieval of the filter would be possible. But sadly, because of the size of the chamber here, there was high risk of filter dislodgement and possibly emboli. And so what we decided to do, we opened the SVC filter at landing zone 2. However, after opening the filter, we did not deploy it. You could see from the video here that it was nice. And then we placed 2 ECOS catheters through the SVC filter. And the last video here, you could see that the ECOS catheters went smoothly through the filter and the location of the filter was not changed. And then the patient received 24 hours of ultrasound-assisted thrombolysis at the critical care unit, and symptoms improved significantly. After ECOS thrombolysis, angiography could see that thrombi had almost completely resolved, and the SVC filter was still in place, even without deploying. So at this time, because the SVC filter and we retrieved the in situ filter successfully, you could see that there was much thrombus on the filter that we retrieved. And the thrombus here would theoretically become pulmonary embolism if we did not place the filter there. Final venography showed good flow from bilateral subclavian veins. And most importantly, the improvement was sustained even now up to 2 months after the procedure. In SVC syndrome, and so balloon and cautiously rather than aggressively. Secondly, filters are mandatory for catheter-directed thrombolysis in SVC thrombus. The concern you could see from this video here that SVC filters are applicable in these conditions. And last but not least, are no good landing zones. Opening the filter without deployment is something that we could do. Our case here showed that this is safe and all presentation. Thank you very much.
Thank you for your nice, interesting case. And of course, I have never seen such a case. So, and any question and comment?
Sorry.
Any question and comment from panelist?
This is the case report, or this is the usually you see? And because yes, I agree that this is for me it's new. Regarding the 2 kissing stents and one, or you can do only one stent and then doing the filter, because if you do 2 kissing stents and multiply, so sometimes it's difficult to put inside the filter. This will be because it is 2 stents inside, so it's difficult to deploy it. So why don't you do only 1 stent and then dilate other?
I hear you very interrupt. I'm sorry. From my understanding, your question was why we deployed 2 stents.
Yes.
Instead,
because can do only 1 stent in order for the filter to pass easily.
Yes. Okay. So initially we placed 2 stents because the patient's lesion extended to both subclavian veins. And so stenting only one side would not treat the other side.
I know, but it's sometimes
because initially her lesion, the filling. Yes. So initially we deployed sync-based.
Okay.
And then after balloon dilatation, we could see that was very bad in the SVC. There were already 2 stents in the SVC. So what we did was, because the lesion, the film at that time extended from both subclavian veins into the SVC, and so we placed 2 stents because it extended into both subclavian veins, and all 2 stents in the SVC at that time when we did bailout stenting. I'm not sure if I answered your question because I did not your entire question.
Okay, great.
Very clearly, I'm sorry.
Any question for the panelists? I think we can close because
yes.
I think yes. What do you think? I think we can close. Okay.
Okay. Please start our next presentation.
Okay. Now, Dr. Panja, about complications post PCI in a case of LED calcified lesion.
So very important, very extremely rare complication post PCI in cases of LED calcified lesions. And here is the patient, 81 years, male, ex-smokers, chest pain presented with unstable angina since 4 days to 5 days. He is a non-hypertensive, diabetes, hypercholesteremia, and evidence of anterolateral wall ischemia there. So patient diagnosed with the unstable angina. And angio shows LED long proximal calcified lesions, 85 to 90%, with a gross irregularity of the proximal part of the LED. And distal RCA, 85% lesion with some PDA, 50 to 60% involvement also there. So my plan is double vessel angioplasty. So I taken the decision. So this is the angio of LED and some calcified lesion and proximal part of the LED. There are some irregularity. I don't know why the calcium chunk up, or it is some other things is available there, whether some micro aneurysm, I don't know. Anyhow, and then this another view also, so calcified lesion and fluoroscopy also better seeing the calcification. And right coronary artery, the distal RCA, just bifurcation of PD and PLV is there, and the PD also some gross disease about 85%. So right coronary artery, first I attempt the right coronary artery. I cannot reach to my stent and the balloon not unable to cross at the beginning. I have to take the 2 wire. So one wire in the PD and another wire up to the distal end for RCA. So double wire technique, I use it to cross the lesion. And therefore, And that's after doing the repeated dilatation, stent is placed, onyx is placed distal to RCA before the bifurcations. I given the balloon on the PDA, no stent I given the PDA. So the acceptable result on the right side. Next, I attempted for the intervention to the LAD. So I've taken them dilated. After I wire cross, I used the cyan blue to cross the lesion with a great difficulty. I used the NC balloon. Initially is a 1.5, then 2.5, then ultimately 3.5 NC balloon repeatedly dilated subsequently. And ultimately I appreciable result by the plain balloon. I was reluctant to use the rotor. That day rotor is out of order in my cath lab. So I have the repeated sequential dilatation of NC balloon from proximal LAD. So ultimately you see the appreciable result on the extreme right, that is the appreciable result by the balloon. Then I give the stent 3.5 into 34 millimeter DSS stent, crossed with a great difficulty, you see, from proximal end to distal. And then it is the appreciable result. So to reach cross the lesion, a distal lesion, I face the difficulty. With the repeated difficulty, again you have to redilate the distal end of the calcium with NC balloon, that is 3.10. Then I able to cross the distal lesion with the stent. So this is the final result. I think the appreciable good result of the putting the stent. And on follow-up, patient was discharged, asymptomatic, hemodynamic stable, and I give the ticagrelor, and 90 BD, and ecosprin, aspirin, and statin, anti-diabetic. After 2 weeks, patient complained of the chest pain. ECG shows no fresh changes. He was advised to medical therapy. Next week, after 2 weeks, on the third week, patient readmitted because of refractory to medical therapy. And check angio revealed huge aneurysm proximal end of the LAD stenting, and RCA stent was patent after 3 weeks. You see here, the check angio revealed huge aneurysm at the proximal end of the LAD, and RCA stent patent I see. And the size of the aneurysm here, they about 15 to 20 millimeters, you see. And ultimately this is the result. What can be done? I take a decision because it is a large, huge aneurysm. You have to do the surgery. So dictum is that if I give the cover stent, the chance of restenosis, rethrombus is more in my experience. So any thrombus, any aneurysm more than 15, we have to take the help of the surgery. So I requested my surgeon to do the LAB graft, and he is the patient. Immediately the patient is referred to surgeon for a repair of the aneurysm, followed by the Lima graft on LAD. The graft in there, ultimately during surgery. Diabetes, calcified lesion with irregularity, proximal end of LAD lesion, suspected to PCI DSA. Eventually, after 2 weeks, patient presented with chest pain, and after 3 weeks after the surgery, after the first angioplasty, huge aneurysm at the proximal end of the stent. Cause of aneurysm due to my experience is due to trauma because of repeated post-dilatation as well as pre-dilatations, and finally aneurysm repaired by surgical interference and Lima graft. Patient discharged, and patient, it is the 3-month follow-up, patient doing well. Thank you very much for patient hearing.
I think it's a very interesting case. Excellent presentations. But we have to discuss what the cause of aneurysm. You said that because of dilatation. Is any other possibility from the panels as well and from you because it is not so common to find aneurysm after repeated dilatation.
Yes, this is interesting finding. So I thought whether due to infection or not. So I reported 5 cases in the JAK imaging long time before infection reusability. This patient I not used anything, and blood count with a normal lipid, and CRP also 2.5 in a normal. Blood culture shows negativity. So therefore, there is no evidence of infection in this patient. And second thing, my impression, and second thing, due to drug sensitivity, hypersensitive to drug, and the polymer may be responsible in some cases. But I don't believe in these cases. I believe due to repeated peridilatation and putting the post-dilatation to get the good result after stent, and that is the most important cause for the aneurysm.
Okay, what's the name of the stent? Sorry.
The TSS
what
stent.
Is the name of the...
I use the stent in the Onyx, Medtronic Onyx stent. Yes.
Okay. Any other possibility with the panels?
That's very, very interesting. So very impressive. So did you do IVUS or OCT for the check what's going on inside of the vessel?
No, initially during the procedures, I've not used the IVUS or OCT. So I'm not, because of the financial constraint of this patient, I not use this thing. But angiographically good result after putting the stent. Excellent result on angiographically.
Yeah. So
one thing that is, if you see the angio on the beginning, some bulging at the proximal end of there. I thought some micro aneurysm there. After repeated dilatation is pre-dilatation, and the size of the aneurysm increase. Perhaps maybe due to so. I think the small microaneurysm at the beginning with atherosclerotic origin was present most likely in this patient.
And you did lima to LAD grafting to resolve the problem. And at the surgical field, did the surgeon remove the aneurysm or just let it be there?
No. He left it there, and aneurysm full of thrombus. He given all the ligation of the neck of the aneurysm, only ligation.
Okay.
Yeah, that's one thing.
I think you make a more trial to passage of the stents as you see here, and you according to this you do more friction to the artery, and then you make a post dilatation in a calcified vessels, maybe stent fracture, something like this, and this stimulates the formation. It could be like this. That's why the question of IVUS, I think it's a good idea for IVUS, but
yeah,
even the surgeon, you already have the surgeon, so the surgeon say only there is a thrombus, nothing with the stents.
No, actually, till speaking, initially during the final procedure, there are not any evidence for any bulging any places. So routinely you should do it. I not done it, but I done the FFR. There's no gradient over the stent. So post PCI, I done the gradient. There is no gradient by FFR.
Any other comments from the panels?
Yeah, hi, Dr. Panjab, for your excellent case. Just now you said that the surgeon didn't ligate it and they found thrombus. Could it be intramuscular hematoma? Because aneurysm to form in such a short period, I have never seen it. I mean, we have seen it like years, but to form in such a short period, just 3 weeks, I'm wondering whether it's a hematoma. Because recently I've encountered cases like that. Post-complex PCI, they do develop hematoma. Is it a hematoma? What did the surgeon say?
Yeah, the surgeon, because long-standing, some clot is not, the whole aneurysm not full of clot. Then some evidence of clot is there within the aneurysm. That is no evidence of the hematoma. If it is hematoma, it shouldn't be localized. It should be spread along the artery. You see, the fusiform type of that. It is circular swelling is there. So I believe it is not a hematoma. And this aneurysm to repeated dilatation, I think in the beginning, the angio shows this small, very micro aneurysm present at the proximal end of the lesion. It was there.
Okay. Thank you very much. Because of time, it's a very interesting case, a unique case for aneurysm, and I think the lesson from this is you should do a rotaplator for the patients. or shock wave or something like that in order to debulk, rather than doing trauma to the artery, rather than bringing into mural hematoma or aneurysm, something like that. Thank you very much for this case. Looking for the next case, closure heterogenic RVOT injury by implantable vascular plug by Dr. Shang from Taiwan.
Okay, thank you very much indeed.
Okay, bye.
Ladies and gentlemen, it's my great pleasure to be here presenting a case of right ventricular perforation caused by pericardial centesis and successfully treated with an implantable vascular plug. This 89-year-old lady came to our emergency room due to progressive shortness of breath for 3 days. She had past history of hypertension, DN, and one episode of anterior STEMI, treated with primary PCI for LAD lesion in 2017. Initial chest X-ray showed left pleural effusion, pneumonia page, and suspect cardiomegaly. Her EKG showed atrial fibrillation with no other specific finding. Because the situation of a respiratory failure intubation was performed, but her blood pressure, fluid hydration, inotropic agent, which is partial collapse of her left lower lung, bilateral pleural effusion, and pericardial effusion around 1 centimeter, encircling the whole heart. Echography was performed immediately and confirmed the diagnosis of cardiotamponade. So her tentative diagnosis was pneumonia with respiratory failure and septic endotracheal intubation with mechanical ventilator support, cardiotamponade with unstable hemodynamic. Pericardial centesis was suggested and agreed by the family. Pericardial centesis was done at our emergency room with a 6 French pigtail catheter through parasternal approach. But flush blood was drenched out from this pigtail rapidly, so we stopped vacuum drainage and repeat echo with normal saline bubble test, confirming misplacement of pigtail inside right ventricle. Given this situation, we consult surgeons first to solve the misplaced pigtail, but surgical removal plus RV repair was not considered due to advanced age, poor general condition, and less high mortality rate. The rate withdrawal of this pigtail may be another option, but we need to take the risk of uncontrolled RV free wall rupture, and the patient may not survive if tamponade progresses. So percutaneous closure using novel device may be the only way to go in this patient. At first, we did pericardial centesis again in our cath lab by subside approach under fluoro and echo guide to relieve cardiotamponade. Then we of the misplaced pigtail in RVOT by contrast injection. We put a super stiff derumo wire to exchange this pigtail for a 6 French short switch for delivering the closure device. We introduced a 6 mini AVP-II closure device into the 6 French device and deployed the proximal. After that, we did wiggle test to follow up. Echography showed the device was in appropriate position and no further increase of pericardial effusion. The closure device could be identified on follow chest X-ray. After procedure, the patient admitted to our intensive care unit. We removed the pigtail of pericardial space after 3 days, and we removed her endotracheal tube 1 week later. We had same pericardial effusion and pleural effusion, which suspect pneumonic related. She finally discharged after 1 month under stable condition. Management of misplaced catheter in heart chambers due to mistake pericardial centesis includes surgical removal plus repair. The rate removal followed by Regarding percutaneous closure of iatrogenic heart perforation during pericardial stentosis, several devices have been reported to seal the perforated hole effectively and safely for patients. These devices include NG-Seal, vascular closure device, and SD occluder. Drawback: NG-Seal has risk of full plate migration to pulmonary trunk and the failure of sealing the perforation hole. And the profile of SD occluder is too bulky, needing large bore delivery sheaths, delay embolization, and potential thromboembolism. The advantage of Emplaza vest plug, including steady position by 2 discs, retrievable and adjustable during deployment, reliable sealing of the perforation when oversized for at least 2/4 of the hole diameter, nearly 0% possibility for device embolization. And this is my take-home message. Echo-guided pericardial stentosis without fluoroscopy carries the risk of misplacement of the catheter into heart chambers. In this circumstance, normal saline bubble test could help determine the accurate catheter position inside the heart and guide subsequent management. Percutaneous closure using an AVP-II device is a feasible approach to seal RV perforation hole caused by pericardial stentosis and could be considered as an alternative to open surgery in patients with high surgical risk. Thanks for your attention.
Thank you very much. This is a very interesting and very practical. I have already before, maybe a few years ago, a case like this, and I put it. This is following PCI and perforation, tamponade, and this patient happened in the ICU, not in the cath lab, and then I put it the sheath inside the right ventricle and tried to make it. But at that time, I left the sheath because it is in the right ventricle, although I have a normal saline bubble. So I have to put the duplications. I left the sheath for a long time and make it a conserve, not the device. So what do you think that in every case of right ventricular puncture, either you don't have cases needed for device and other cases need for conservative? How can you differentiate? Because this device is not applicable in every center. So how can you segregate the patient into maybe a small puncture, large puncture? How can you differentiate?
In this case, we chose the device because we make the wind of the heart by 6 French pigtail, and we have the AVP-II in our hospital, so we didn't think too much and chose the device.
Okay. Any question for the panelists?
Thank you for your nice presentation, Dr. Low. I have one question for you. Is there any concern in terms of long-term not outcome limitation, because the heart is always beating, so the implant device has a tip or some material, it's not that round, so heart is beating, so it might irritate the pericardium all the time. So is there any concern over reporting after putting the implant and making irritation, effusion, something like that?
We have searched the consequence of the device, but what we search is only case report in this condition. So we didn't have the long-term outcome of these patients. But as we know, it's that due to the high surgical risk to this patient, we think.
Thank you.
Any other comments?
Thanks, Dr. Low. I'm Dr. Liu. Thanks for your good, excellent presentation. And in my opinion, I think the patient's heart is not so big after your great treatment. I think maybe conservative treatment is another option. After use another pericardial centrosis, and then measure the heart size and measure the RP pressure. Maybe just direct removal of the catheter maybe is suitable because the patient heart is not so big. Maybe the RP pressure is not high. Yeah.
Yes, we have seen the choice, but in that time, her blood pressure dropped to 90/50 at our emergency room. So we think if we remove the catheter in the heart chamber and the tamponade progress, we will lose the catheter to deploy device to solve this problem. So we chose not to take the risk of the tamponade progress.
Regarding the echo-guided and fluoroscopy, for example, in our department in the university, and sometimes in the student, if they have a tamponade, we do it a lot in echo-guided, not with fluoroscopy. I like the fluoroscopy. I'm the old generation which is started by fluoroscopy. But nowadays, if you are expert doing an echo, sometimes it's the advice is doing the normal saline injection to be sure that you are not in the right ventricle. So do you have a lesson from this case to the audience, how to prevent doing right ventricular puncture rather than doing devices? You have two options, echo-guided and fluoroscopy, and you have both. How can you differentiate? What's your lessons to them? Because I'm saying to you, it's not to do the complication in order not to do the device, because it's not so safe to put a device in a contracting heart. So how can we prevent it?
Maybe next time, if the pericardial effusion is not had a little amount, we can send the patient to cath lab and choose fluoro and echo guide both. Maybe it can prevent the complication.
So large effusion in echo, small effusion going to the fluoroscopy. Am I right?
Yes.
May I ask Dr. Loh? I think the case is well done. My question to you is that, do you consider an ABG? ABG, when you puncture the pericardium, in this case that looks like the puncture is into the RV. Do you consider using an ABG to differentiate whether it's in pericardial space or in RV?
Yes, but we didn't think at that time.
It's for me, I think most of the time we know that the pericardial tapping is sometimes can be quite complicated. Yeah. So one of the ways sometimes I use is to use an ABG to guide me. If it's in the LV, then of course, from the ABG it can tell you. Yeah, roughly guide that whether you're in the wrong chamber or wrong lumen or not.
But sometimes you get it how the blood is clotting or not. If you have a clot, so you are in the right ventricle. If no clot, this is in the pericardium. The second, that the saline, as he said, that you inject saline, see the bubble, where the bubble is going the right ventricle, so you puncture the right ventricle. Okay, thank you very much. It was very interesting technique, and I learned personally a lot from you regarding the device. Thank you very much. I think we have to wrap up. Dr. Yaj, we can wrap up before we going into the last speaker. Okay. I think we have today, before midnight, Kilot Adventure by Dr. Ahmad Rashad from Tanta. We have 4 cases today. We have 2 calcifications, one with aneurysm, which is very interesting. We don't know till now the mechanism, maybe the maneuvers, maybe inflammations. And the second one with the CTO calcifications, how to use the device, the stringy device, the anti-grade device. But both of them needs maybe in the future you have to do a debulking rather than using the balloon. I think we have mixed. Just last week I saw with Antonio Colombo doing the mixed with the Rota or Rota Link with the shockwave. Sometimes you can debulk by two techniques. The third one, which is for me is new, is the stenting of the SVC. It's a very, very interesting case, doing 2 stents and then doing Amplatzer, maybe a device, this filter. It was so difficult, but she did a great job for helping the patient rather than to have pulmonary embolization. And the last today with Dr. Shang, which is also a lesson to all of us, how to prevent the puncture to the right ventricle. And when you puncture, how to treat it. You should have in your core lab Amplatzer and somebody who knows how to deploy the Amplatzer in order to prevent the complication for right ventricular perforation. And thank you very much, and looking for Dr. Ahmed Rashad.
This is a case of complex PCI in the form of bifurcational technique involving left main branch in the name of Midnight Keylog Adventure by Ahmed Rashad, Tanta University, Cardiology Department, Egypt. 75 years old female with no significant medical or surgical history presented to our department with severe chest pain of 3-hour duration. Her physical examination was unremarkable and she was hemodynamically stable. Investigations revealed ECG showed ST elevation in posterior and lateral leads. Her echocardiogram showed fair ejection fraction with hypokinesia of lateral and posterior walls. Her lab showed positive troponin with creatinine 1 milligram per deciliter. She was soon sent to cath lab. Radial axis was used, which showed ostial left main critical lesion with subtotal osteoproximal LAD and ramus branches. The CX was small, non-dominant vessel with proximal segment subtotal occlusion. Her right coronary showed no significant lesion. Here, what about the plan? We are in front of bifurcational lesion, Medina class 111, and the most important 2 questions in bifurcational strategy is, does the side branch need to be preserved? And in this case, sure, yes. And the second question, what is the likelihood of side branch occlusion? And in this case, in such case, it's very high because of the critical stenosis of LAD and ramus branches and the high probability of plaque shift during stenting of post branches. So we prefer to do 2-stent technique, not 1-stent technique. The viable 2 options here are Keylog technique or DK crush technique because of acute angle between both side branches. We prefer to do Keylog technique as the size of both branches are nearly the same and the angle between 2 branches isn't very clear. We also are familiar with Keylog technique, so we prefer to do that. Regarding PCI procedure, prior to insertion, the XB guide catheter was preloaded with 2 BMW wires. The first wire or the vessel wire was shaped using standard technique according to the LAD curvature, and an exaggerated loop was formed to use as a floating wire. Floating wire is very important in left main or ostial RCA lesions to prevent the deep engagement of the guide catheter and prevent hemodynamic collapse. The vessel wire was easily advanced into the LAD, and the catheter then carefully disengaged or was drawn to disengage left main while constantly maintaining the distal wire position. Next to the floating wire, another wire was advanced to the ramus branch. Now we have 3 wires, one in the LAD, one in the ramus branch, and the one is floating. Then the left main, the LED and the ramus lesions was pre-dilated with 1.5 by 12 non-compliant balloon, and this is the result after pre-dilatation. Here. Then we proceeded to placement a drug-eluting stent 3x38 to the left main LED and was deployed, and multiple projection was taken to confirm its position and the coverage of the lesion. Then put proximal optimization of the stent in the left main was done by NC balloon 4.5 by 12. Now the wire of the ramus is jailed, so meticulous distal rewiring was done to the jailed wire of the ramus. And this is very important to form or reform the shape of the carina, followed by kissing technique with NC balloon 3 by 12 in the LED and the ramus branches. Here. Another drug-eluting stent, 2.75 by 38, was advanced and deployed in the left main ramus with minimal protrusion into the left main, intending for mini-kilot technique. Here, this is followed by second put, which was done by the previous balloon of the left main. After put, another distal rewiring and second kissing balloon using the same two balloons, 3 by 12 each in the left in the LED and the ramus, followed by final put using the same balloon of the left main NC balloon 4.5 by 12 with an excellent final result. Here is the kissing, followed by put, and here is the final result. Excellent final result. In this case, we choose radial axis in primary PCI, and we use two-stent technique in primary PCI. In patients with acute, to conclude, in patients with acute Crohn syndrome, the final TME flow together with the residual lesion will shape the long-term outcome in such patients. In spite of being debatable, two-stent technique in acute setting may be practiced, provided the good preparation of the whole team. And when choosing two-stent technique in acute setting, techniques with minimal stent overlaps and metal layers may be preferable, such as the TAP, but in our patient with such an acute angle between both branches, mini-kilot with minimal overlap is a viable option, especially when the size of the two side branches are nearly equal. Thank you.
Thank you very much. And I learned a lot of things from this session. And I think we have a good discussion about the complex PCI. Thank you very much.
Okay.
Thank you.
Goodbye.
Thank you.
Bye.
Great job.
Right.